Well, good morning, everyone. For those who don't know me, I'm Ryan Leone. I'm one of the chief residents. Dr. Leonard was unfortunately unable to be here, so I'm here on behalf of the Pediatric Grand Rounds Committee to make some quick introductions and reminders. So glad to see you all here, and we have many on Zoom. Just a quick reminder to text for your attendance. All the information is up there. And we just want to highlight some wonderful upcoming speakers. In recognition of Women's in Medicine Month this September, we have Dr. Nancy Spector coming from Drexel. She'll be joining us next Friday. And then we're already kicking off October, and we have Dr. Paul Sanchez from New Mexico to honor Hispanic Heritage Month. Another reminder that Grand Rounds is eligible for both CME and ABP MOC Part 2 credit. You can scan that QR code to complete the session evaluation and then submit your session reflection. We also wanted to highlight the Physician Leadership Certificate Program for physicians this October. They're now accepting their 2023 cohort applicants, and the deadline is October 10th. You can scan that QR code to get to the website for some more information. It's a wonderful opportunity. And I'm going to now turn it over to Dr. Profit to introduce our amazing speaker for today.
Good morning, everybody. In person for the first time and on Zoom for many of you. I'm really honored to introduce our guest today. And I'm going to kind of alternate between my German and English, because usually I'd say Dr. Poets, but because he's from Germany, I'll say Professor Poets. So Professor Poets graduated from Hanover Medical School in Germany in 1986, and he stayed on to train there in pediatric pulmonology and neonatology. He also did a research fellowship at the London Heart and Lung Institute, came back to Hanover, rose through the ranks, and was director of the neonatal intensive care unit and the pediatric sleep lab, not the combination you hear very often, in 1994. In 2004, he moved to the southwest of Germany, to Tuebingen, which is pretty close to Heidelberg, if some of you may have heard of that city, and he became chair and medical director of the Department of Neonatology. Then in 2008, he became the inaugural chair for the newly established multidisciplinary Center for Cleft, Palate, and Craniofacial Malformations. And since 2020, he's been also the acting chair of pediatrics at the Tuebingen University Children's Hospital. Professor Poets is an extremely accomplished scientist. He has authored over 400 articles in the peer-reviewed literature. He's a true Renaissance man, with widely divergent research interests spanning the breadth of scientific endeavor, including the basic sciences, bioengineering, translational research, clinical trials, and quality improvement. Today, we are honored to learn about his pioneering work for patients with craniofacial malformations, particularly Pierre-Robin sequence, for which he and his colleagues in Tübingen have developed a novel paradigm-shifting therapeutic approach. We at Stanford are lucky to have Dr. Hiran Chu as our colleague, who has been pioneering the same treatment at Stanford as the first center really in the United States to adopt this. And so with no further ado, Professor Poets.
Yeah, thanks, Jochen. And Hiran, thanks for inviting me. So this is the title of my talk. And basically, it is something that was also completely new to me before I came to Tübingen. And the approach I'm going to tell you a little bit about the next half an hour or so was developed by an orthodontist, a very dedicated woman. I always told her, you should have become a pediatrician rather than an orthodontist, because she was such a caring personality. And it's really very heartwarming to see that he is an orthodontist called Hiran, who is actually of the same structure. And I think without that commitment, it would be impossible, because I mean, this is so different to producing braces. What I see is normally your professional task, because this really requires dedication to the baby, and you will see that in a minute why. Basically, and you are all familiar with that, craniofacial malformations do form a rather diverse spectrum. Pierre-Robin or Robin, actually, I prefer the term Robin sequence because it's unusual to include the first name of the person first describing it. It was Pierre Robin, a Parisian stomatologist, but I mean, we also use the second name for other conditions. So I prefer to say Robin. And this is characterized by the trias of glossoptosis, so the backward movement of the tongue, a small or retropositioned mandible, and upper airway obstruction. And this condition may be associated with craniodysostosis, like Treacher-Collins syndrome or Goldenhaar syndrome, but also with craniosynostosis, like Crouzon or Pfeiffer syndrome. And as already said, the common denominator is the upper airway obstruction and a huge or very significant failure to thrive. So because these are the main clinical problems, I also think that our treatment actually should focus on these two aspects, and we have two tools for that. For the for the upper airway obstruction, which is particularly severe during sleep, it is the sleep study, and that was probably the luck we had in Tübingen, that I happened to meet there this orthodontist, and I had this background in sleep medicine. My first research assignment was sudden infant death syndrome as a very young doctor, and that's what brought me actually to London. My boss simply told me, "This guy has left the department, please take over." That was my choice for getting familiarized with sudden infant death syndrome, but it proved out to be very fruitful because it concerns so many various aspects of our professional obligations here. And basically, so this sleep study is really crucial here, and also a very simple tool. We have to monitor weight, and apparently that is not really done in a very systematic way with many of these patients, although it is so easy to weigh them in regular intervals and to insert their weight data into one of these weight charts, so that you actually notice, for example, with this baby who was born at around on around the 10th centile, then dropped below the 3rd centile, and with the treatment we started here, he went up to the 25th and then 50th centile. So, and this is what I will tell you later. This is quite quite normal what we see with these kids. But I would like, before I talk about this approach which we developed in Tübingen, what is normal? What is the normal kind of treatment for these babies? And if you look into the literature, they all recommend the prone sleep position. And that kind of didn't resonate with me, being a SITS expert, as already mentioned, because I had learned, or we had learned the hard way in this field, that SITS, that prone position is quite a strong risk factor for sudden infant death syndrome. I mean, the largest, one of the best studies in this field is a European cohort study across really 14 European countries, and they came up with an odds ratio of 13.9. That's very high, and a very strong and highly significant risk factor. And that there's no reason to believe that the pathomechanism resulting in this, or being responsible for this association between SITS and prone sleeping should not apply to Robin kids. I mean, it's too rare a condition to come up with data, but I think it's a kind of risky decision to send a baby home with the recommendation of sleeping prone. And the other thing is, we think it is effective, but I guess it's mainly because we don't see the respiratory distress these babies have if they're lying on their tummy. You don't see the chest and the paradoxical breathing that much. Because if you look into the recent literature, they did proper sleep studies. For example, this study from France here on 18 infants showed that there was absolutely no significant change in the obstructive apnea-hypopnea index. So it was not effective in that study, and other studies show the same. A larger study from Finland reported, yes, it was statistically significant if the babies were put in the prone position, but 3/4 continue to have an obstructive apnea-hypopnea index of more than 5, which is in pediatrics normally our treatment threshold. So they still needed treatment after having been placed prone. So that's not an answer, I think. I mean, it may help a little bit, but it's not sufficient to say, and it's dangerous. So it's really not a good idea, basically. Now, this is something, and this was a patient sent to us from another hospital with glossopexy and tongue-lip adhesion. And it reminds me of the medieval times, to be honest. I mean, I'm sorry, I'm a bit biased here, but I take a neonatologist's view. We have become pretty big fans of minimal handling. This is not minimal handling. And the babies can't really develop sucking and swallowing with this tongue not being able to move properly. And if you look at the literature, not surprisingly, data on weight gain are rather disappointing. And sleep study data are very rare, and I will show you in a minute. And in the older studies, there are also quite frightening and high side effect rates, wound resistance or scars developing, and severe infections in up to 1/4 of babies. And internationally, most popular is probably this one here, the mandibular distraction osteogenesis. This was one of our patients from Hanover. Our maxillofacial surgeons also did this operation occasionally. But also, again, this is an operation that is actually fraught with side effects. And I'll never forget this young guy here, a 9-year-old boy who was operated on with Robin sequence as in the first year of life. And since then had developed an ankylosis of his temporomandibular joint and couldn't close his mouth anymore. It was that does to a human being, if you can't close your mouth anymore, it's terrible. He constantly walked with very strange posture because it affects your entire spine if you can't close the mouth. And sorry, I don't want to put too much bias into this, but this is just my experience with other treatments. And I come to what I was doing in Hanover in a minute. These are the data. I entered the PubMed search just a few days ago, entering Robin sequence, mandibular distraction. And there were 250 hits, and then I added polysomnography. There were only 37, so almost 1/10 of the studies. I mean, how can you do an operation without proving objectively that it is effective? Very strange. But if you add then a comparison with TLA, which is the other predominant operative procedure for these babies, you come up with these 3 studies listed here, are summarized here. And what you can see, at least the MDO is effective. The obstructive apnea-hypopnea index drops down from 34 to 1 in this study, or from 47 to 2 or 2.6 in this study, and from 38 to 5.7. But TLA is much less effective. I mean, in this study, it did the job, but in the other studies, it really was associated with still a rather unacceptably high mixed obstructive apnea-hypopnea index. And this is basically how our craniofacial surgeon treated this in Hanover, where I trained, as Jochen mentioned. And this is mandibular traction. You put a wire around the mandible, and you put a weight onto it, and then you constantly pull. And the baby is forced to be immobilized by pain, because obviously it's a very painful procedure. As soon as you move, it hurts. And there are very, very few studies on this intervention, although it is still widely used in several countries around the world. And the largest study is from an Italian center. They applied it to about 1/2 of their 246, also a large center, Robin children. And they say that saturation normalized. But if you look at their data, I mean, this is the data taken from this figure, taken from their paper. And before the intervention, their median saturation was in the low 70s. I mean, I can't believe that this is true, because you can't have a saturation constantly around 70%, but that's what they write in the paper. So I'm not sure who has reviewed that paper, but this person can't have done a proper job, really. But anyway, they say it's normalizing, but no sleep. It was just pulse oximetry. No sleep study results. Then the nasopharyngeal airway. That's very popular in the UK. Great Ormond Street Hospital in London has a lot of patients treated with this intervention. And it's basically, you just take an ET tube and you position it that it just ends above the epiglottis, and you cut it close to the nose. The position must be checked frequently, because a few millimeters can actually either mean that you are aspirating, or it can mean that the treatment is not effective anymore. The British group reported that their weight centiles improved significantly, but they provided, unfortunately, no sleep data. And the other critique I have, although we also use this occasionally as a bridging therapy, does not provide any incentive on the mandible to grow, because it's not addressing the functional problem of Robin sequence, the lack of to be able to swallow and suck. This is taken from the Great Ormond Street Hospital publication. They developed an adapter to make it easier to fixate to keep the airway in place. So it is not as invasive as many other treatments. And I mean, it's funny to see how it differs by country. The French, particularly in France, but also in Lyon or in Nantes, use CPAP. That's also a bridging therapy, no question about that. The French colleagues have reported a small case series in pediatrics 10 years ago, and basically report that the time with desaturation was significantly reduced from 14 to 1%. And CO2 measured through the skin was also improving significantly from 57 to 31 milligrams of mercury. But my main concern with this treatment is that you may actually worsen the already pre-existing maxillary hypoplasia. And that's also something I learned from my colleagues in orthodontics in Tuebingen, that Robin sequence babies do not only have a small jaw, but also a small maxilla. You don't see it because the mandible is so much smaller, but it's definitely there. And that's also obstructing the airway. Inside, you don't see it inside the skull. And it was Christian Guilleminault from this sleep center here, the Stanford Sleep Center, one of the godfathers of sleep medicine, who published this paper here showing what a severe retrotrusion and maxillary hypoplasia you can develop if you wear this CPAP device for a long time. And this was in a toddler. But here we are talking about infants, where the structures are much more modifiable by constant pressure. So and if I look at the baby, I mean, parents won't like it to have their baby constantly wrapped into this device day and night. Tracheostomy is obviously the ultimate option. And I'm, as somebody coming from Europe, I'm always surprised how quickly you are, sorry for saying this, in this country with making this decision. In a questionnaire study in US centers for craniofacial malformations, half of respondents considered tracheostomy the treatment of choice as soon as prone position had failed. And given the disappointing effectiveness of the prone position mentioned earlier, that means you ending up with high numbers of tracheostomies. But this is not a harmless procedure. It's fraught with 2 or 3% mortality. It's very costly. Another US study has estimated that the cost amount to $90,000 per patient. So it's an ultimate choice. Before the baby dies, it's obviously necessary. I'm not questioning that, but I think it should really be the last resort rather than something you consider as soon as prone position has failed. Right, and now I come to palatal plates. And this is actually a publication that's rather old, from 1967, from Northern Ireland. This doctor used an obturator, a palatal plate, I would call it these days, that had a kind of elongation, a slight elongation that kind of helped perhaps to move the tongue into the correct position. But this report, although published in the Archives of Disease in Childhood, which is quite an influential journal, received very little attention. And I must admit, I came across it only by chance, really. But our orthodontist in Tübingen had also read this paper and thought that perhaps the extension here you see on the slide here should perhaps be a little bit longer. ending just above the epiglottis. And that's basically her trick, if I may say so. That was her invention, the important addition. And she inserted a metal wire to make sure that the spur doesn't break, because the forces acting on the spur actually can be quite high. So this is something you need to make sure that your device doesn't break. But with that wire inside, it doesn't break. And that's how it looks in situ, so to speak. In this drawing, the tongue is automatically moved from its upright position, which is the definition of glossoptosis, to a more normal position shown here. And that will also allow the baby to learn how to suck and swallow. But it's really a functional treatment. And I need to stress that it's not enough to just order one of these plates, but this is absolutely important to combine it with functional treatment. We always do orofacial stimulation, according to Castillo Morales, an orthodont physiotherapist from Argentina. And our team has learned quite well how to apply this. And this is what you see if you endoscope the babies. And this may be frightening to you, but in my centers, it's absolutely normal that the neonatologist is doing the endoscopy, which in practical terms helps a great deal, because you don't have to wait for an ENT specialist. You do it at the bedside. Yeah, I mean, occasionally we have to invite the ENT specialist, and I know what I'm talking about. Wait, it always takes a few days. Okay, it's only a problem in Tuebingen, I accept that. But you see immediately that this is the blue structure here is the spur ending just above the epiglottis. It's immediately opening the airway. And I will illustrate this with this series of short videos. If you look at this little guy, he has severe dyspnea because of this upper airway obstruction, the Aubin sequence phenotype. Obviously, he has a nasogastric tube, and you see how much difficulty he has breathing. And then you put the baby on the tummy, on the prone position. Sorry, and the baby still has the problem. You don't see it as much as before. You don't see the retractions anymore. But the problem, as I already said, is still there. And then you insert the plate. Baby goes to sleep immediately because he suddenly can breathe easily and freely, and you don't hear a sound. And this is just a subjective impression. I don't want to bias you too much. This is German introducing the plate, also another rather old video. This is basically how we do it. And it's done in less than a minute. And it doesn't seem too unpleasant. I mean, you sometimes wonder whether they are actually, why don't they start to retch? But because it's not touching the backside of your throat, but only the ventral side of it, it doesn't result in retching. And then we do the endoscopy to check whether it's if it's a new plate, and that's what we have filmed here, whether that's the spur ends just above the epiglottis. You need this endoscopy to make sure that you're not damaging the structures which are very sensible there in the pharynx. And this is basically our timeline. We admit the baby. Nowadays, we do a scan. We have developed a fully digital workflow. So we produce a scan rather than an impression taken. And then we produce the first prototype, still without the metal wire inside. And then we insert it and do an endoscopy and check whether it's fitting all right. And as soon as we think, yes, it's fitting all right, and the angulation of the spur is also okay, pushing the base of the tongue sufficiently forward to open the airway, but not too much, because otherwise pressure marks would develop. Then we do a sleep study to see whether it's effective. And if we still have the feeling it can be improved, we modify the plate. We have to repeat the sleep study occasionally, and we have to repeat the endoscopy occasionally. But that's basically how it is. And our median duration of hospital stay is 16 days across 300 babies, so a really large cohort. Sleep studies, as already mentioned, are really important, and that's what you see. The nasal flow is again and again interrupted, whereas the baby continues to make breathing efforts. The saturation fluctuates, but we can have severe upper airway obstruction, unfortunately, without the pulse oximeter showing it. So you can't be sure that you have frequent desaturation, but you still have significant upper airway obstruction. That's why I'm absolutely convinced. And I mean, my main subject for many years, research subject, was pulse oximetry. So I'm a big fan of pulse oximetry. But for this condition, it is not sensitive enough. You will miss quite a significant proportion of patients if you are just doing a pulse oximetry. You will obviously identify the tip of the iceberg, but the iceberg underneath the water is quite large. And I'm not sure whether any sleep specialists are here in the audience or in the online forum. We have been criticized that we are always doing the mixed obstructive apnea index and not the hypopnea index. And we recently did a study to see the difference between the two parameters. And basically, yes, the mixed obstructive apnea hypopnea index results in almost twice the index. So they are twice as common as the apneas only. But basically, if you keep that in mind and perhaps use a different treatment threshold, we have a treatment threshold of 3 for many years, and compared to the conventional threshold of 5, so you end up with the 5 that's in place. Otherwise, if you include the hypopneas, and the reason why we ignored them, because we don't do full polysomnography. Although I'm a sleep specialist and I know how to read a sleep study with the EEG, I see these babies are so compromised by their upper airway obstruction that any additional procedure to them, they don't tolerate. And because it's not giving me really important additional information, because I'm not after neurological problems or seizure-induced apneas or something like that, but I know what the pathophysiology here is, I think the addition of the full PSG can be omitted. And that's why we have decided to do that for the last 20 years. And then after these 2 weeks or a few days more, we talk to the parents and make sure that they have learned how to insert, remove, and clean the plate. They must be removed once daily to check the mucosa for any pressure marks. We do a sleep study in the supine position. And here the mixed obstructive apnea index should be below 3. And then we send the baby home on a pulse oximeter, simply because parents need to become aware if the plate is dislodged and baby develop upper airway obstruction, that doesn't happen in the middle of the night and the parents don't notice that. And that's again one of these weight charts. You see how much they improved their weight with the plate inside. And also for scientific evaluations, we calculate the Z-score on weight. So the 1Z is 1 standard deviation, below or above the mean. And for example, in this study, where we did a national survey to see how Robin sequence is treated in my country, in Germany, and I was kind of interested to see that out of 138 infants reported, 51 had been treated with the at the time we called it the pre-obstructive Baton plate. Nowadays you call it the Tuebingen palatal plate. It's the same. And that's not only our center. So it is being used by at least 9 other centers in Germany that I'm aware of, maybe more these days. So it's nothing very special. And I must admit that none of these other 8 centers has come to Tübingen to learn how to do it. So anyway, that's how it is. But what I want to say is that infants who had severe phenotype that needed emergency interventions for their breathing problems were also those which had a much lower Z-score. So their weight gain was much more problematic than in the infants without emergency interventions. And also to monitor treatment effectiveness. For example, here we compared our weight data with the other centers' weight data, and difference between admission to hospital and discharge was 0. Basically, the infants had stayed in their center they had at the time they were admitted, whereas in the other centers, they had lost 3/4 of a standard deviation of their weight, which is quite a high number, really, given that we are talking about 2 or 3 weeks of hospital stay. And also on a larger scale, for example, here we analyzed data from 307 infants data with isolated Rouban sequence over a 20-year period, non-needing tracheostomy. And basically, we are also not doing a really good job because the babies are already admitted with a negative Z score. So they have already lost some weight between being born and being admitted to our center. So if more than one standard deviation, and we don't fully manage to get catch-up weight, but by the time they reach 1 year of age, they have halved their delay in growth. So it's getting better, but not fully normal within the first year. Feeding is a major issue. As I said, it's a functional treatment, and you need to combine this plate with this functional treatment. I must admit here, our nurses are really doing a good job. We do have, as I already said, physiotherapists or speech therapists to help them, and also particularly to train the parents. But the nurses, because they are there day and night, and the speech therapist is there only 5 times a week for half an hour, it's not the same. And we use these Platex bottles, which are squeezable bottles produced here in the United States. So we import them because you can't get them on the German market via Amazon, actually. Yeah. And it's really helpful because with these bottles, it's much easier to control the milk flow. Because otherwise, with normal feeds, I sometimes have the impression that it's almost like waterboarding. It's not a good practice. And this is just another example of how it looks in reality.
Komm auf deine Seite, Kinder, oder? Nee, mach's mal von der Seite, damit man mal nicht über die Magersonde mit drauf.
I should actually, the sound is, he's doing a great job there. But it is a procedure that requires patience on this, both the baby actually and the caregiver. Because in utero, they have learned it the wrong way. I mean, you know that babies are also, fetuses are also swallowing thicker, but it is, they have to learn it because in utero, their tongue is totally in the wrong position. But they do. I mean, 90% of our babies are fully orally fed, not via tube, by the time they go home after weeks. So, after having shown you this treatment, how it works, I just want to address a few questions. First, is this plate more effective than a sham procedure? So we did the randomized controlled trial. I mean, I'm a neonatologist, so I'm used to the value of randomized controlled trials. So I wanted to have this also here because there still is, except for the one I'll show you in a minute, no randomized trial at all for any intervention for this condition. And then we wanted to know whether it's also effective in severe phenotypes, because at conferences I was always being told by the colleagues from ENT, from craniofacial maxillofacial surgery, yes, this works in the mild phenotypes you see in Tuebingen, but our patients are much worse. They can't be managed. So I come to that in a minute. Then the important question is there mandibular catch-up growth? And then is it only feasible in Tuebingen or also elsewhere? Now, with regard to this controlled trial, we did a sham procedure. We just inserted a plate without the extension. For ethical reasons, we felt we could only do that for 2 days. So we did a repeat sleep study after the one done at admission, and after both interventions. And basically, we focused again on the mixed obstructive apnea index and found that this had actually decreased from 14 to 4 within these 48 hours with the Tuebingen palatal plate, and had stayed in the same range at around 15 with the conventional palatal plate. And also the saturation index had significantly improved, but not significantly so with the sham procedure. And we did an extension to this study time-wise, and the mixed obstructive apnea index then moved down to 1 after, I think, 2 weeks, and the CO2 normalized, and the weight gain was also improved. And with regard to effectiveness in severe phenotypes, we looked at a sample of 122 infants with Rouban sequence, and we divided into 3 groups depending on their mixed obstructive apnea index at admission. And we had the most severe group here with a mean index of 30. And mind you, this would correspond to an index of 60 with your sleep studies here doing full polysomnography. That's quite a high value, 60 obstructive events per hour, 1 every minute. And that normalized to 0.2 at the 3-month follow-up, in the same range as in the other 2 groups. So it doesn't really matter how severe the phenotype is with isolated infants. And for syndromic ones, that is kind of a different kettle of fish, if I may say so. Some are really problematic. And sometimes we have to use modifications where we attach a tube or a tubular structure to the spur, or even do a kind of airway plate, or this one here. So there, the orthodontist has to become really very innovative. But with that approach, we looked at or analyzed data from 68 consecutive patients, and 56 completed treatment. 3 we had to tracheostomize. So that's in this particular group that may also happen. So it's not a perfect treatment. There are failures clearly, and also very important. The main group of diagnosis that's not compatible with the plate treatment are babies with severe swallowing disorders, and a lot of saliva production. Because it will particularly initially, it increases certain incentive that saliva production increases. And that's, for example, the case in charge association babies who also have quite often mandibular hypoplasia. So they would benefit from such a plate, but they don't tolerate it because they can't swallow. And Wiedemann and Beckwith, those with a larger tongue, have also difficulties coping with the plate. And what we do in with these diagnoses, we give it a try. You never know in advance, but only for a few days. And then we see, is there an effect, or is the baby not coping with it? And then we switch over to other treatments. And altogether with these 68 patients, the mixed obstructive apnea index also decreased into the range shown for the isolated cases. So it's equally effective, but there are exceptions. Treatment failures is the better word. The question now is, does it also work elsewhere? And to address that, we collaborated with 2 other centers in Cologne and Würzburg, in other 2 German cities. And we also had introduced this treatment before we contacted them. So we knew that they had experience with that. And we asked them to feed their data prospectively into a database. And basically, the decrease in the mixed obstructive apnea index was very similar to the data just from Tuebingen shown earlier. So it can also be done elsewhere. And the prime example here is our colleague here, Hairan Chu, who actually developed this treatment or introduced this treatment, as already said here, to Stanford without having come to Tuebingen to see how it works, just from reading our papers very carefully. Congratulations that you really achieved this, and you published data on that, and your sleep study data also very impressive. So it is equally effective here than it is back home. And the advantage you had that in at least these 2 patients you published in the Cleft Palate Craniofacial journal, you could do CTs, so you can actually could demonstrate how the bones actually grow. The catch-up growth. We had to use non-invasive approaches to monitor catch-up growth. There is a publication on the so-called jaw index, publication from the Netherlands, where you can actually monitor mandibular growth non-invasively with a measuring tape, and basically found that the jaw index had improved significantly in these babies. But although this paper has been published, I must criticize it myself. These measurements were done not blinded to the condition of the baby. So we kind of repeated this study in a slightly larger sample, and prospectively, we recruited 19 consecutive row-bound infants and 31 controls. And we did 3D photography, and we used measuring points on advice from the colleagues in orthodontics. And you see how over time the data from the normal infants became similar to the ones from the Robin infants. So basically, although they haven't become fully identical after the 6 months period where we monitored that, they have become very similar already. So it's definitely inducing a catch-up growth. And this is the logo from a meeting we had that was actually based on a father doing a side view of his baby with Robin sequence every 2 weeks. So we could basically choose which ones the most helpful. And you can see immediately how the mandible has actually grown forward, resulting in a totally normal facial profile after 9 months. But that's a one-off case, so the scientific evaluation, I think, is much more important here. And as already said, we are moving to a digital procedure. We are scanning now and rather than impression taking, and we use 3D printers. And we have very active colleagues in a group for biomedical engineering. And we are now measuring this person to derive at a catalog that can help other centers to know what dimensions they have to attain in their patients. But that's the future, and I won't talk about that. And it's quite interesting to see is just last 2 weeks ago, a center from Bratislava in Slovak Republic in Eastern Europe published this case study where they also did CT scans, how the plate was actually fitting into the anatomy on the CT picture. I don't have this because for ethical reasons we don't do CTs, but it's always interesting to see. And this is also sort of modification where they don't use the metal wires to keep the plate in place, but had this 3D printed extension here configured. Whether that's good or not, I can't comment on. So I'm at the end of my presentation. I have tried to convince you that severe obstructive sleep apnea and failure to thrive are the main clinical problems in Robin sequence. That the plate I presented to you is effective in almost all instances isolated Robin, and in more than 80% of those with syndromic Robin. It may help to avoid more invasive or purely bridging treatment options like tracheostomy or CPAP. Its effectiveness must be monitored through sleep studies and weight monitoring. And we are currently in the process of setting up a register, or we have already set it up. And we have already in a collaboration agreement with a center in Harvard. They also feed their data. They are big fans of mandibular distraction, so that we have a control of mandibular distraction, because you can't do randomized controlled trials with different treatment approaches here. But at least some registry data will tell you a little bit more how well the outcome is comparable between one intervention or another. And with that, I would like to leave you and would be absolutely happy to take any questions. Thank you.
Thank you. Is this working? Thank you so much for the wonderful presentation. It's really groundbreaking and very excited about it. Are there any questions in the audience or on Zoom? I just wanted to bring Dr. Chu here so everybody kind of can see her and knows who she is. If you see her walking around the hospital, you may not know. She'll be handling the questions on Zoom.
Very good point.
So we'll have to repeat the question.
Yes, how long do we keep the plate in place? And that's basically for 3 to 4 months. So if the baby comes as a neonate, the treatment is usually done with by 4 months. I'm not sure how you do it here in Stanford, but that's our experience.
Very similar, between about 3 to 6 months. Like on average, I would say about 4 to 5 months.
And it's interesting, the younger the baby is admitted, the sooner the treatment is over.
That's so true.
So the growth potential is probably largest in the neonatal age. And it's good to, I mean, ideally, but unfortunately, I'm not sure how it is in this country, the prenatal ultrasound experts are not that good. Only 16% of our infants with Robin are identified prenatally. And only 11% are actually referred antenatally and then giving birth in our center, which would be the ideal because it doesn't put the infant at any risk. But as I said, the detection rate is not very satisfying here.
We have actually 5 questions from our online audience, and then I will read the first question is, what is the effect on breastfeeding with these appliances, and how many years is the duration of the therapy typically? But it's not years, usually months. And how often do the devices need to be upsized?
Yes, also very, very good questions. Yes, breastfeeding is possible. If you are working in this area, you know that breastfeeding success rates are not very high in infants with cleft, partly because mothers are quite stressed, which doesn't improve the milk flow, but also partly because it's not that pleasant a feeling with the nipple and the plate. So in some babies, we just do a breastfeeding exercise when the plate is being taken out for cleaning. So yes, we put a lot of weight on that, and nowadays about half the babies are going home breastfed. But that's only half, because normally we're at 80%. So there we can still improve, but we are working on it. And one of our specialists in this field from the neonatal side is also a certified lactation consultant. So she is doing a great job with basically encouraging the parents not to give up, really. And the other question was how long?
How often do you need to upsize the device?
Yes, normally the first larger plate is needed after 6 to 8 weeks. But normally, actually, the second plate is the last plate. So as I said, the growth potential is largest in the neonatal age. So it's pretty normal after 6 to 8 weeks that they have to come back for a larger plate. But then until the mandible has moved sufficiently forward that we don't need the plate anymore, we rarely need the third plate, but it does happen occasionally.
Just to let you know, at Stanford, we kind of see the baby monthly basis just to make sure the growth is not restricted. And then quite often, a very minimal adjustment, but definitely we increase especially the palatal component of the device. So second question is, do you use 3D printers for rapid prototyping for the device? Yes,
we do that. And as I said, that's where I think the future is also. Yeah. But that is such a complicated process, and our technicians are really excellent in doing that. They're actually biomedical engineers, not just technicians. And that's beyond my core competence. So I better leave that to them. But the answer is clearly yes. We only these days, the last imprint we took was about a year and a half ago. So we're not doing imprints anymore. It's all scanning. It works very well.
So it starts with the intraoral scanning and then directly to the 3D printing. Okay. The next question is, are you aware of any centers in low and middle income countries using this device?
Yeah, very good question, because it's ideal for that kind of setting. Although ideal is perhaps not the best word here. But if anything works in this kind of setting, it's most likely to be this one, because it's comparatively easy. And I'm aware of colleagues in India having introduced this, and in China. I mean, China is not a third world country. I should be careful here. But in India, definitely. And we have one colleague from Mumbai who will actually come over for 3 months, starting about after Christmas. So he will learn how to do the print of and the whole setup. And so we hope that it will catch up also in countries like India.
Wonderful. I mean, at Stanford, I'm having a lot of difficulties with the IRB before starting any of this process, but I think definitely agree this is the future. Another question is, thank you for the excellent presentation. I'm curious if you have considered this therapy in babies slightly older than 6 months.
Well, the problem is with tooth eruption. If there are tooth eruptions, because this is basically the plate is also covering the what's the word? Alveolar ridge.
Yeah.
it doesn't really work. You have to modify the plate too often
Yes.
if it's in the process of this tooth eruption. So we ideally make sure that we have more or less done before the teeth start to erupt.
Yeah, and also by that age, the babies becomes like exponentially active, and they're gonna pull things, and they're not gonna be very cooperative. So that's why, and also their growth spurt kind of plateaus a little bit from the age 6 months toward. So within the 6 months, I think this is the prime time to start this treatment.
Yeah.
Next question is, do changes to the spur width help with the swallowing? So I guess adjusting the the tail portion, would it help swallowing?
I mean, we occasionally have, the main problem is not to be too aggressive. So it's better to have inclination of the spur where you know the upper obstruction won't be resolved, but the baby has then more time to get used to it and still swallow nicely and become a little bit more ambitious after a few days and then move the spur a little bit forward. Although you have to produce a new plate, but the production cost, I mean, this costs $10. It's nothing, because but with the 3D printing, it has become really cheap. So yes, then we do a new plate with a different angulation of the spur.
Yeah, yeah. I mean, neonatal, aerodigestive, the study itself is very, very complex and really complicated to study. And we're dealing with this very dynamic movement. So but bottom line is to improve baby swallowing, actually even improve or make it happen. The very first thing we need to control is having a very competent breathing. Once the breathing is resolved, then we can actually rule out is the breathing is the true source of dysphagia, or the baby has a different situation in addition to the breathing. So I think that's a big first step to clear out, to investigate what's the root cause to the dysphagia. So the last question today is that fascinating data. Do you have an explanation for why mandibular hypoplasia resolves from this intervention?
Yes, it gives a growth incentive, and particularly because the function is normalized. The function, there's a paradigm in your specialty, orthodontics, form follows function. So if the function is normalized, the form will normalize also. And that's a proof that this paradigm is actually a true one.
Yep.
And that's, I mean, I was looking for the data. I mean, in these 307 infants, after 3 months, none of them had a feeding tube anymore. So they all can grow normally without a feeding tube. Perhaps not always within the 2-week time they stay in our unit, but within 2 or 3 months, definitely every baby will be fully orally fed.
That's really fantastic. Amazing. Maybe finish with one last question, which I find intriguing regarding the different patient population, just the trisomy 21 babies, which have a lot of obstructive sleep apnea, and just your general thoughts on what might be possible for them.
Yes, thanks for raising this question. We have a program where we do routine sleep studies at 6 weeks of age in all of these babies with Down syndrome. And we identify quite a high proportion, 1/3 already have significant upper airway obstruction at that age. And we do start with a plate, although they don't have a cleft, but the plate with a stimulation knob and without the spur. The stimulation knob, again, this functional treatment. And there are publications from the 1970s in Germany. That was not our invention. It's really an old technique, that the stimulation knob will help the tongue to assume, it's like bodybuilding for the tongue, because it has this muscular hypotonia, and with this stimulation knob, the tongue is constantly moved forward to the front teeth, and that will prevent the mouth from staying open, as so often the case in Down syndrome infants otherwise. And if they have a high mixed obstructive apnea index, then they also may get a palatal plate with a spur. So about 10% of our Down syndrome kids are also getting a Tuebingen palatal plate, although they don't have a cleft, which is much more tricky because there's less space in the pharynx. But if there's, I mean, the alternative is CPAP. which is also not a good idea in Down syndrome, because they also have this maxillary hyperplasia, so which may get worsened by the CPAP mask.
Well, thank you so much for this wonderful talk and for sharing your expertise.
My pleasure. Thanks for having me.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.